Thank you. So I am Dennis Krause. I'm the director for head and neck oncology at North Shore Long Island Jewish Cancer Center. And my co-moderator is John Irish, who's the provincial head of surgical oncology program, Cancer Care of Toronto, and John's titles go on and on. We have the privilege of moderating the video panel today, and we've obviously sold out the room. So we're going to have four speakers. Professor Jesus Medina, Emeritus Professor, University of Oklahoma, is going to talk on management of the N0 neck. Professor Mark Izzard is going to talk on management of the N-positive neck. Dr. Thompson from the Mayo Clinic, management of the central compartment and papillary thyroid cancer. And Professor Nobu from Kobe, Japan, will talk on management of the lateral neck and papillary thyroid cancer. There we go. I have no disclosures. So if you think about it, in a little over 100 years, we've come a long way from the work of Dr. Kreil, and I had the good fortune to have done my original surgical training at the Cleveland Clinic. If you think about Dr. Kreil's original treatise, the concept of doing en bloc neck dissection was done with patients in shock trousers, and the risk of mortality was well into the into double digits. Subsequent progress in the field occurred at my other alma mater, Memorial Sloan Kettering Cancer Center, and we all heard a very eloquent Hayes Martin lectureship by Pat Gillane this morning, talking about what Dr. Martin would think. And again, this was the great treatise on neck dissection that Dr. Martin wrote in 1949. It's ironic, Bill Cahan, who's the last author, was actually one of the attendings when I initially joined the staff at Memorial. And if you, again, look for progress, and this is the question that everyone tends to ask us, this is what the people who moderated today, is when are you guys going to make some progress in cancer care? When are we going to do better? And the answer, I think, is pretty eloquently shown, if I can get my slides to advance, here. And this is a slide from Dr. Martin, in which he says the single most reliable predictor of survival for squamous carcinoma of the head and neck is the status of the neck nodes. Metastatic disease of the neck reduces survival by approximately 1/2. And I think that, and again, this is just a quick jump-off point for the presentations that are going to be made today. But if you take this statement and you compare this, and this is, again, data from Memorial. This is one of the last papers that I wrote there on the faculty. And this was our experience with N-positive necks. This is a group of 130 patients who had an N-positive neck, all of whom underwent a type 3 modified radical neck dissection. So it was selected patients. It wasn't all patients. You can see the vast majority of patients were oral cavity. It's interesting to note that 16% had prior therapy. There's a total of 11.5% incidence of recurrence in the neck. We have disease-specific survival of 70%. Contrast that to the statement that survival in the neck positive nodes in the neck for squamous carcinoma reduces survival by 1/2, and now we have disease-specific survival of 70%. And if you look at isolated recurrence in the dissected neck, it's under 5%. So again, I think the answer is 100 years of progress have been substantial. I think we've made tremendous inroads, both in terms of the oncology and the functional nature. And you're going to see that we're going to have 4 outstanding experts to address this from a technical standpoint. With no further ado, Dr. Medina.